So this is osteoarthritis and degenerative disc disease. It's found on starting on page 676 of your textbook. It's something that you're going to see a lot in practice. It's something that you're probably, excuse me, going to get to a certain extent. It's very, very widespread in North America. It's got a lot to do with our lifestyle. So it is a slow degenerative change, degenerative joint disease that involves the articular cartilage of a synovial joint. It's especially prevalent in the weight-bearing joints, in the knees and the hips, or in joints that get used a lot, like the interphalangeal joints. The difficulty I have with calling it osteoarthritis is that we hear OA, but the patient, the layperson, hears arthritis, and they immediately think of rheumatoid arthritis. And, you know, Aunt Florence had rheumatoid arthritis, and she ended up in a wheelchair, so am I going to have it? And it does it run in the families, and, you know, et cetera, et cetera. It really is a wear and tear sort of degenerative change. There's a primary osteoarthritis that is really idiopathic. It just happens, not because of something else. And then there's secondary, and it's usually secondary to some sort of either trauma or an infection or an osteonecrosis, something that has triggered it. So people that have been in car accidents, for instance, will get osteoarthritis of the facet joints of their cervical spine post-whiplash. People that have had falls or played a lot of sports and taken injuries to their knees will end up with OA in the knee, and that would be secondary to that trauma, to that injury. But then again, a lot of people just have an idiopathic primary one. It's really a very common disease. It's 60% in men, 70% of women later in life. It's an awful lot of people have it. It's the most common musculoskeletal disorder affecting hands, knees, and the weight-bearing joints. And it costs the healthcare system a lot of money. There's a lot of hospital visits happen because of it, a lot of surgeries happen because of it, et cetera, et cetera. So what causes it is something goes wrong with the environment inside the joint, and the joint gets damaged. So the synovial membrane stops producing liquid. There's a trauma to the joint cartilage itself, and the joint cartilage is damaged, and it doesn't reverse. And one of the problems with joint cartilage is that it is a real connective tissue with far more matrix than chondrocytes. And it's completely avascular. So the only way that it gets nutrients to those chondrocytes is through suscication, through loading and unloading. It's like wringing a sponge out of dirty water and sucking in clean water. And so joints have to be used, but they have to be loaded and unloaded correctly for this to work properly. It's very, very resistant to compressive forces, not so much on shearing force, so forces that move sideways across the joint. So what ends up happening is that the joints get damaged, and when the joint surface gets damaged, the cartilage doesn't repair very well. although chondrocytes are active, they are constantly replacing and rebuilding. It's right where those chondrocytes are. If a chondrocyte a couple of millimeters over dies, then the healthy one doesn't migrate into the area and recover the spot, and that's one of the problems here. Is so. If the chondrocyte dies because of trauma or because of lack of nutrients, then and that cartilage is damaged, then you don't get matrix at that area, and that cartilage degrades and starts to cause problems. So when that happens, oftentimes what happens is the joint becomes slightly unstable, and you grow bone, and you grow bone spurs, or you have like bony degeneration underneath the cartilage. And when that happens, the cartilage gets even rougher, the loading becomes less even, and there's more inflammation, which then disturbs the cartilage health of the remaining cartilage, and the thing progresses. And that's why it's a progressive degenerative problem. So as we age, we tend to dry out, and cartilage is a very wet tissue. It needs to be. So as we dry out, there's problems. A lot of us have got weight problems, especially later in life, and that puts an unbelievable amount of stress on the weight-bearing joints, knees and hips specifically. Old ligamentous damage, so strains and sprains, ligamentous sprains, that don't adequately heal, can cause this instability. And this instability means that the joint doesn't load and unload correctly, and therefore can get damaged. Repetitive pounding stresses, so a lot of times just like jogging, running, that kind of thing. History of trauma. A roommate of mine was in a car accident one time, years before he was my roommate, and he wasn't wearing a seatbelt, and he brought both his knees up. He was a passenger. He brought both his knees up as he realized they were going to hit, and he pounded both knees into the dashboard of the car, into the glove compartment, and he ended up, 10 years later, with osteoarthritis in both knees. They call it chondromalacia patella because it was sick cartilage behind his patella, and then it continued to degenerate into osteoarthritis. Less often there can be things like nutritional deficiencies, things that cause systemic sort of inflammations, like that kind of thing. Another problem that's not listed here, but is a real problem, and I think it's in your book, is that weak muscles can lead to it. So a lot of times what happens is, as elderly people, end up in a wheelchair, for instance, and the muscles become very weak and atrophy, then the joints don't load very well, and so that actually increases the problems. Prolonged immobilization can lead to this. So you need this moderate amount of exercise. Not enough exercise causes it, and too much, like especially heavy sports like hockey and soccer and things like that, can cause it. Trauma can cause it. So how do you know when you have it? You get this deep, deep pain and a certain amount of stiffness. you get widening of the joints and a limited joint range of motion. So at the distal and the proximal interphalangeal joints, they get bony, and you've all seen, you know, like old ladies' hands where the joints get really big. That's OA. There's people get up in the morning, and they have this stiffness, and it lasts for about a half an hour usually until they kind of get going. So if you have a patient that says that when they get up in the morning they can hardly walk to the bathroom until they get going, you know, maybe once they get out of the shower it seems to be better. They call that joint gelling. And it often, well, I say a half an hour, but it could be as short as 10 minutes, depending on what the morning routine is. You kind of can walk it out and get through it. It's especially prevalent in the knees and hips. Something else that you get is crepitus, and I don't know if you know that, but it's an audible cracking, or there's a grating sensation. The joints don't move smoothly, so oftentimes you'll move the knee and you'll kind of hear and you'll feel a grating sound. It can be really disconcerting for people, and it may not even be painful at that point, just stiff and crepitus. The pain kind of comes and goes with use in those early things. You got to take a really good history, and because the patient will tell you what's wrong with them. Now, the big thing about osteoarthritis is that it's inflamed joints. And there's a lot of things that can inflame joints, a lot of systemic things, there's a lot of different types of arthritis, and you kind of have to rule out the other ones before. Now, it says radiography, x-rays aren't conclusive, but they sure are indicative. Oftentimes, you will see bony spurs, osteophyte formation that forms around the joints. It's almost like the joints are trying to become more stable. So what do you try and do with this? It's pretty hard to reverse the damage, but you try and limit the spread of the damage. Because it's degenerative, if you can slow down the rate of degeneration, then you're doing people a huge favor. That's kind of one of the things that you're shooting for. Most people end up taking nonsteroidal anti-inflammatories. So that would be just Advil and naproxen, things like that. They seem to work, but they're hard on the kidneys, they're hard on the liver, they're hard on a few things like that. There are various topical applications, so deep cold, icy hot, some of those things, Voltaren, some of those things seem to bring some relief of pain. It's a great idea to get these people exercising, because what that does is it helps develop sessication. It helps with the range of motion. It helps with the muscle strength, and it improves the joints, the cartilage itself. Exercise is considered a kind of a controversial thing with osteoarthritis. Most people with OA don't particularly want to exercise because it can be painful, and or at least they can have the trepidation of it being painful. So that's a deterrent. But if one of the etiologies of it is being overweight, then losing weight is a great way to slow at least the rate of degeneration. That's an important thing. Kind of the less muscle tone that you have, the more effective exercise is. Generally speaking, we usually talk about doing non-weight bearing exercise, things like aquafit and you know, maybe stationary bike, that kind of thing. It seems to be much better than weight bearing, pounding sort of things. And that combined with nonsteroidal anti-inflammatories seems to be the way that most people go. When you have people exercise, one of the things they should do is ice before the exercise and then warm up to it, like a good long period of warm-up exercise to to kind of beat the inflammation before it starts, and it causes less pain. There's a lot of talk now about glucosamine, especially glucosamine and chondroitin. All the studies are coming back positive. A guy that I went to school with is he's a PhD in pathophysiology, and he's doing some research at the University of Waterloo right now on osteoarthritis and nutritional supplements, specifically glucosamine in it, and it's showing some really good results. An interesting story is my brother's dog had osteoarthritis in the hips, and they would come visit, and he'd play with my kids all day, and then the next day we'd have to carry him up the stairs. And my brother started taking glucosamine for his knees, and whatever he put in his mouth, the dog wanted one, so he started giving the dog glucosamine. Well, pretty soon the dog was able to play and then walk up the stairs the next day. It seemed to really significantly improve his hips. That was a big selling point for me, because dogs can't really go on the placebo effect. So there's some downsides to glucosamine, and it's something that you should be aware of. Glucosamine, as it sounds, there's glucose, so it can trigger insulin, and it can screw up people with diabetes, with blood sugar problems. So you got to be careful around it with that. And there's an awful lot of elderly people with type 2 diabetes that are overweight and have OA at the knees and hips. So they have to be careful. Most of the supplements are made from shellfish, so you got to be very careful if there's shellfish allergies. And the chondroitin sulfate, which really makes the glucosamine more effective, will affect blood clotting. So if people are on blood thinners already, like on Coumadin or things like that, they can end up with some severe bleeding problems. My uncle started taking glucosamine for OA of his knees and hips, and he ended up getting a nosebleed, and he had had a series of small strokes, so he was on blood thinners, he was on Coumadin, and he developed a nosebleed one day, and it wouldn't stop, so he went to the hospital in Timmins, and they couldn't get it stopped there. They ended up air ambulancing him to North Bay, where they had to surgically cauterize and get the blood to stop flowing. But he told me that the first thing that the doctor said to him is, do you take glucosamine with chondroitin? Uh, and he said yes. And she said, you've got to stop it right away, because uh, it really accentuates the Coumadin or the warfarin. So he ended up in really bad trouble. He lost a lot of blood because of that. And he told me that story right after it happened as a warning, because he knew that I was recommending glucosamine to a lot of my patients. I became very aware of it after that point. A lot of people get surgical procedures for OA. They get corticosteroids, cortisone injections right into the joint. They have arthroscopic scrapings and that thing, so that's called debridement. The joint gets washed out. They try and remove debris or anything that's in the joint with lavage, which really means washing out. And all of this is sometimes works, it sometimes doesn't. They all have their side effects. Sometimes it helps with the pain in the short term, but speeds up the progression. So I don't know, it all becomes a choice. The last resort is joint replacement surgery. A lot of knees and a lot of hips get replaced every year. My mother-in-law has had both knees replaced. I can't tell you how many patients have had a knee or a hip replacement surgery. Very common, especially in a certain age group, like kind of that over 70 crowd. They all just wonder when their turn is going to be. They're working on a whole bunch of things. One of the things that they realize is that chondrocytes don't migrate. But what if you harvest chondrocytes from someplace and transplant them? Like, say you take the little plugs out of the costal cartilages, the hyaline cartilage of the ribs, and kind of plug it into the knee or the hip as cartilage replacement. And you know, it's your cartilage, and it should kind of seed and grow there. It kind of somehow reminds me of hair transplants, but whatever. It's showing promise. The other ones I don't know very much about, cartilage paste and that kind of thing. For a while there, they were looking at gels that to replace the synovial fluid, which gives more lubrication but less nutrients. So I really doubt the efficacy of that. Now, osteoarthritis can happen in any synovial joint. A very similar disease, similar to OA, is DDD, degenerative disc disease. And really, it's not osteoarthritis because it's not a synovial joint. The disc is actually a symphysis. So, but again, this is hugely, hugely, hugely common. In our society, most of us would drive to the bathroom if we could get the car in the house. We exercise in spurts. We sit for long periods of time, and then we over-exercise instead of just kind of spreading it out through the day. And it's very hard on our discs and on our joints. So when we look at an intervertebral disc, there's the annulus fibrosus that goes around the outside, and the inside is this nucleus pulposa. And the fibers, like any rope, are strong when there's load on them, when it's tight, and when they're slack, they flop around. And will spread apart from one another. So the problem with the annulus getting kind of slack is that it can it doesn't contain the nucleus, so the nucleus kind of spreads out a little bit. So then the annulus really starts to degenerate everywhere, just naturally, kind of in your fourth decade, someplace around age of 30. You got to be. What'll happen is there's cracks, or there can be fissures, or anything like that. So what happens is this, and you can see that what in this figure that the two vertebrae have come closer together, and it's like letting air out of a tire. If you let air out of the tire, the rim gets closer to the ground, but the tire gets wider. It kind of bulges on either side of the rim, and it's the same sort of thing. Now you'll notice that as this bulges, the annulus, the fibers, start to pull outwards on the edges of the vertebral body. You can see it in you see it in here, how there will be a pull, and bone grows in relation to the stresses placed upon it. So what will happen is osteophytes will grow here and kind of spread. So kind of one of the first things that you note is that the two vertebrae get closer together, and then the disc starts to bulge out beyond the edge of the vertebrae. Then osteophytes will form here. So now every now and then the annulus will split, and the fibers will actually separate, and the nucleus will herniate right out. It looks like a bulge in a bicycle tire where the inner tube pushes through the sidewall. It's the same sort of thing. Now, oftentimes this follows degenerative disc disease, but it also can happen if there's a sudden load, like a fall or something like that. Very seldom will it completely rupture, but if the disc herniates, then it becomes a problem of where does that tissue go? What does it push against? Does it entrap nerves? Does it push in against the spinal cord itself and cause a spinal stenosis? Most of the symptoms from a herniated disc are actually neurological, and it's usually in the limbs. If it's the lumbar spine, it will be sciatic sort of pain. So this really talks about how you get it. If you're in flexion and then come upright quickly, so like you're lifting something, what happens is when you go into flexion, forward flexion, you're putting a lot of pressure on the disc, and the disc squeezes at the front and opens at the back, and then you come up quickly, and that the nucleus gets pushed right against the annulus and can break through if the annulus is cracked. Then you get inflammation, etc. Now, most of the time, it goes laterally and pinches a nerve root, and you get a radiculopathy at that nerve root. This is why you were learning the myotomes and the dermatomes, or you will be, to identify which nerve root can be affected. Quite painful. People usually present when this happens with an extended back. What they do is they want their spine to be extended rather than flex. Flexion puts more pressure on the disc, and especially at the front of the disc, which pushes that bulge further back against the nerve. When they extend, it takes the pressure off the disc. People with osteoarthritis of the facet joints, however, are the exact opposite. Extension of the spine hurts the by putting pressure on the facet joints, and and forward flexion actually relieves the pain. So people with facet joint problems come in bent over. People uh, with disc problems tend to present with extension in the spine. Uh, like I say, the radicular pain is the big thing. Radiations. So sciatica would be the big one, uh, and that's from pressure on the nerve and the inflammation there. Oftentimes they go numb or tingly, so they end up with paresthesia. They get very specific muscle weaknesses depending on which motor uh, thing that it is. So, for instance, if there is a disc herniation at C5, then the deltoid gets weak, and people have trouble. They lose strength in abducting their arm um, because of it. So later you will learn all the myotomes and the dermatomes if you haven't started already, because a lot of people present with disc disease, disc herniation. It can be really bad if there's a spinal cord compression. It can be a medical emergency and really almost require surgery to decompress the spinal cord. So diagnosis is ruling out other things. Radiography, really, MRIs are the way that it's the standard now. So what's the goal? What you want to do is to suck the nucleus back in and let this thing heal up a little bit. A chiropractic works a lot for it. Osteopaths do a lot of the same sort of things. It's manipulation. What you're trying to do is create space. Lately, there's been a big push for spinal traction. You'll see TV ads and that kind of thing for it. Bed rest, I don't know. I've never seen a lot of good results from bed rest, but sometimes when the pain's really bad, people don't have much choice in that. Medication, muscle relaxants, and painkillers are the big things. So that's like Robaxacet. Again, I have my doubts about whether you can get enough muscle relaxant to help a lot. Lots of surgery is seems to be the way if it's a real bad way thing. So discectomy, what they do is they literally go in there and they suck the nucleus out of the disc, so there's nothing to bulge. They used to, when I first graduated from college, they were doing something called chemonucleolysis, which they put an injection of chymopapine, a derivative of the papaya plant, into the disc and literally digested it. And it's meat tenderizer. It's accent meat tenderizer, and you digest the proteins in the disc, and it just would liquefy and flow away. But it's now illegal to do that in Canada because there were so many adverse reactions. People were having really bad systemic allergic anaphylactic reactions to it. So as far as I know, it's not allowed in Canada anymore. I think they're still doing it in some places, with lots of pre-testing and that kind of thing. These people are going to end up on your table. What happens is there is when the discs are involved, either as degenerative disc disease or worse, a herniation, then muscles tighten around to try and stop movement, to try and splint the joints. And a lot of the pain that people have is from that muscular spasm, which is why muscle relaxants seem to work. you want to make sure that you don't cause undue flexion or extension when you're working on these people. This is really a tag team sort of thing for treatment. Chiropractic, massage therapy, osteopathy all work well together. Physiotherapy, I mean, they all have their place in the rehabilitation of these people.